Welcome, everyone. My name is Joe Kolars, and I'm the director of the Center for Global Health Equity here at the University of Michigan. And it's a real treat for me to have this seminar today that we call Journeys in Global Health. What we like to do with this series is take individuals and try and understand the distance traveled, how they put their career together so that they can be impactful and influential in global health. So often we see people who are the luminaries in their field and we wonder, how did they get there? And it's a special treat that we have with us today, Professor Richard Adanu. He is currently professor at the University of Ghana and rector of the College of Physicians and Surgeons. Rather than going through a long bio and introduction, I'm going to let Professor Adanu tell his story. But maybe I could offer just a statement or two about why we've invited Professor Adanu to be with us today. As many of you may know, we have a long relationship between the University of Michigan and Ghana that goes back to the 1960s. We also have a long relationship in health that dates back over 30 years with champions such as Dr. Tim Johnson, our former chair of OBGYN, who has really played an incredible role in partnering around maternal and child health. Professor Adanu was one of those early partners and has been so instrumental in furthering our collaborations and relationships here at the University of Michigan. I can clearly state that our medical school, our School of Public Health are clearly better because of the relationships we've had, collaborations in Ghana. And Professor Adanu has been one of those champions who have been leading us forward. Our format today is I'm going to turn the floor over to Professor Adanu for him to tell us his story. And then we're going to have a discussion, some facilitated question and answers. So please feel free, as you can see from Alana in the chat box there, to put in your comments, your questions, and I will be weaving them into today's discussion. Richard, thanks so much for being with us today, and I will turn things over to you.
Right, thank you, Joe, for the introduction, and I'm really happy to give this talk today. I mean, so thanks to the Center for inviting me, and like Joe said, I've been I think my first time in Ann Arbor, that was in 2000. So that's 22 years ago. I mean, came in there as a senior resident for a 3-month attachment. And I think since then I've been collaborating with different people from the University of Michigan. But the Ghana-Michigan collaboration started, earlier than that. Before I got in. So my name is Richard Adanu, and I'm currently the rector at the Ghana College of Physicians and Surgeons. So we're going to spend this time just kind of like talking about what my path has been into global health. And sometimes, those of us who live in this part of the world, the low middle income countries, a lot of Africa, when it comes to global health, we kind of like wonder what is global health, because essentially global health is what we do here. So we tend not to refer to it as global health, but then we'll get on with that. So when I think of myself as an academic. One who's developed a career in academic medicine. So I see myself as a teacher. I've taught in medical school and also at the School of Public Health. I see myself as a researcher. My research is mainly in the area of women's reproductive health. done work with maternal mortality and morbidity, family planning, abortion, other aspects of public health, like violence against women, just the whole women's reproductive health gamut. Now, currently, I work essentially as a medical education administrator, and I've done a bit of that. So there's the teacher, researcher, medical education administrator. That's what I see myself as. So how did all this start? So medical school, outside medical school, I did my medical school in Ghana at the University of Ghana Medical School. During that time, I would say I enjoyed all my medical school rotations. There wasn't any particular rotation that I wished I wasn't in. At that time, going through medical school, one of the things I enjoyed the most was the analysis aspect of work that we did in community health. In our medical school curriculum, from the third year, we begin to do lectures in community health all through till the final year, and then there's in the fourth year there's community pediatrics work that we do. In the third year, there's community diagnosis work that we do. The fourth year, there's community pediatrics. Then in the final year of medical school, we do our own independent research. And during that time, I really like the whole aspect of looking at the data, coming out with tables and interpreting what the data were saying. Partly because of that, my main interest when I was finishing medical school was I wanted to specialize in community health. So at that time, my thinking was that I'll do an MPH and then also go ahead and do my residency in community medicine. That was my original thinking by the time I finished medical school. Now in Ghana, after medical school, now it's 2 years, but then in that time it was a 1 year internship that we called house officer period. So 1 year after medical school, we did this house officer rotation. So at that time I did internal medicine and OBGYN. So my first rotation was in internal medicine, that was for 6 months. Then the second 6 months was in OBGYN. So when I was doing my OBGYN rotation, and all these rotations, I enjoyed them and I applied myself fully in everything I was doing. So when I was doing the OBGYN rotation, that was when I began talking with the senior residents and the consultants there. Actually, they began to ask me that, so what are you going to do after this? And I said, after this, I'm going to go into public health. I'm going to do a Master of Public Health and probably specialize in, do a residency in community medicine. And they were all kind of like totally shocked at that. And there were questions like, really, is that what you're going to do? Why are you choosing, why is it that you're applying yourself so much in what we're doing out here, and that's what you want, that's what you're moving out and not going to continue OBGYN? And I said, well, I'm applying myself because this is my job, and I've got to be good at it. So I think I learned how to do a C-section when I was in my house officer year, and do the minor things like evacuation of the uterus and all that. But so everybody was basically thinking I was really crazy. So then the house job ended, and I tried to get a placement in a medical officer rotation that would enable me to pursue this whole public health path. And it just didn't work out. It didn't work out because the hospital that I wanted to be posted to, I was told that was not available. So as I sat down and thought through this, I just said, well, let's go do OBGYN. My attending over there and the senior residents were all happy to have me come do OBGYN. So hey, why not do that? And at that time, I tend to see things from a faith perspective, and my feeling was that, well, whatever it was, God had closed that door for me going into public health. And since everybody was beckoning me to come on into OBGYN, why not? So I remember I walked into my attendance office there. That was Dr. Ghosh, an Indian OBGYN who spent the greater part of his working life in Ghana, and told him that, well, Dr. Ghosh, I've decided that I'll do my medical officership in OBGYN. And I remember that day so well. Dr. Ghosh sat in his office and told me, sit, I'm going to write a letter for you right now before you change your mind. I mean, I don't understand how you moved from the public health back here, but then let's quickly get this done. So he wrote the letter. I mean, those times drafted it by hand, walked with me to the admin office. That letter was typed, and then I got into OBGYN as a medical officer. And when I got in there, one of my first decisions was that, okay, I'm going to do the residency there. I'm going to take the exams and do my residency training in OBGYN. So that's what I did. That was a 5-year residency training in OBGYN in Ghana. This was all done in Ghana. But then as I studied OBGYN and practiced it, I became more convinced about the importance of public health in OBGYN. I mean, the importance of public health interventions in improving maternal mortality and morbidity. I mean, the importance of public health interventions for family planning and all that. So I kept thinking about that I think I would really like to study some public health and see how that applies to OBGYN. So that was when in 2000, I came to Ann Arbor and did a 3-month senior residency attachment at the Department of Obstetrics and Gynecology. And there I met Professor Timothy Johnson. And in talking, he asked me what my career plans were. And I said, I'd like to move into the public health aspect of OBGYN. And that's what I would want to do. So my plan was to go back to Ghana, and then I'll later apply to the University of Ghana School of Public Health and do a Master of Public Health and see how I could apply those things to my practice. And another decision I'd taken at that time was that I would like to be a teacher in the medical school. So my plan was also that after finishing the residency, I was going to apply to join the medical school as a lecturer. So then when I had a conversation with Tim Johnson, he said, well, you've done your medical school and your OB/GYN training in Ghana. Why don't we look to get you into one of the top US public health schools so that you can do that. So I got back to Ghana, finished my residency training, did my GREs, and then got admitted into Johns Hopkins. So I got into Hopkins. I was there as a Gates scholar. So there was a scholarship from the Gates Institute at Johns Hopkins, and so in 2004, I came to the US for a year to do my Master of Public Health training. So by that time, I joined the medical school here in Ghana. So in 2003, I got on faculty at the medical school. I was teaching medical students and also having a practice in OBGYN. So then at Hopkins, because of my funding, I had to concentrate in women's reproductive health. So I selected all the courses that would enable me to do a concentration in women's reproductive health. But like I said earlier on, I'd always been interested in the whole analysis of data thing. So I also took all the quantitative courses. So essentially, during that 11 months at Hopkins, I did 2 concentrations. I did like the whole epibiostat concentration and also did the women's reproductive health concentration. So I was basically running from class to class all through, which was kind of like good. I mean, 1 year away from home. I mean, being in class almost all the time would reduce the pressures of missing home. So I got the training for those quantitative skills, and also was introduced to all the different theories and interventions in the area of women's reproductive health. So that, I would say, is like the training aspect of things. Now, developing as a researcher was is another thing. In early 2000, there was one faculty member, a professor from University of Michigan, who came down to Ghana. That was Nancy Hunt, she was a history professor who was linked with the Department of OBGYN. And she came to lead some research into women's health in Ghana. So I was a senior resident then, I got on that team. And that was when I was introduced to qualitative research. So collected some data, did some qualitative, quantitative things, and eventually got some papers published from that. So Nancy was actually the person who introduced me directly to Tim. I mean, I'd already been accepted to come for the rotation in the University of Michigan. But I remember Nancy going with me to his office and saying, hey, Richard was one of the hardworking research assistants I had. Through that also, I got introduced to Alan Hill and his team from Harvard. So Alan was coming down to Ghana. They were coming to do this women's health study in Accra. So then Nancy had mentioned my name to them. So when Alan came to Ghana, it was in 2003, he invited me they wanted me to be on the project, more like a clinical coordinator on the research project. At that time, I think I'd joined the medical school. So when I met with them then, I kind of like knew that, hey, I wanted to develop a career in research. And I had about 2 papers, I think, at that time. Then Alan comes and they're doing this big study, going to study, recruit about 1,005 women in Accra and just measure the burden of disease. So then at the interview, I basically negotiated being a part of the research team. And just to cut a long story short, let's say they agreed to have me on the research team, not there as a hired hand, but as part of the team. So that was the phase 1 in 2003. And in 2008, 5 years later, we did the phase 2 of that. And at that time, I was on as a co-investigator. So that was one of the big things, in terms of getting into research. So by the time I went to Hopkins in 2004, we had completed a data collection for the 2003 women's health study. And I had some of that data, which I used for some projects in my MPH training. But that was like me growing into the whole public health research field. So I came back from Hopkins and was teaching in the medical school and was actively involved in writing proposals, collecting data, and basically just building up my research portfolio. And when I came back from Hopkins back to Ghana, I also began teaching in the community health department of the University of Ghana Medical School. So then I was teaching public health and also teaching OBGYN at the same time. And then I also got connected with the University of Ghana School of Public Health and was teaching one women's reproductive health course over there. So by that time, so this was about, let's say, 2005, early 2006, I was essentially established as a teacher in OBGYN, a teacher in public health, and was growing in the whole women's reproductive health research. So once that was happening, then let's say different opportunities began to come up. So yes, the news was around in Ghana that there was an OBGYN who had also done public health, who was working in the whole area of women's reproductive health. So then I was asked to come to meetings, serve as an advisor to it's called the Family Health Division of the Ghana Health Service, bringing in my OBGYN and public health knowledge into that. Then there were also collaborations with colleagues from University of Michigan. There was this Minority International Health Research Training Program that I worked with Professor Lengman, who was in Michigan then. Through that, got to know Dr. Sharon Moyer, And we had medical students from Michigan who came down, worked together with other students from Ghana. And that basically launched me into the whole area of research capacity building with public health and medical students. So then I would say my involvement in let's say international work began to develop, and through that, another aspect was that through Professor Timothy Johnson, I was invited to be on the International Journal of Journal of Gynecology and Obstetrics on the editorial board, and that was in 2006, and worked on that board till I think it was in 2014 or 15, yeah, something like that. That I became the editor-in-chief of that journal, and that exposure, being on the editorial board and becoming the editor-in-chief of the International Journal of Gynecology and Obstetrics, really exposed me to the different research questions that people are asking in different parts of the world. And that, I mean, was a learning experience for me, just expanded my horizon and knowing what are the cutting edge questions in that area. And around that time, the whole thing about collaborations also began to grow. So once again, through my links with University of Michigan, through Tim and Dr. Senait Fisser, Senait and I kind of like overlapped in residency training. So then I got linked with Ethiopia and did some work with St. Paul's Hospital in Ethiopia. So with them, it was mainly research capacity strengthening. I mean, holding research courses, for research workshops for junior faculty and for the residents. So I did that with St. Paul for a number of years, just building research capacity. Then another thing was as part of this with my collaborations. So then there was the link with Hopkins. I had a PhD student that I supervised from Hopkins, that's Dr. Osge Tunchal. And Osge later went to work with WHO. And then through Osge, I mean, got to start working as an advisor at WHO, and then eventually became a research collaborator with them. So that's how the international collaborations grew. Working with WHO, I mean, that was into another area of developing policies, interventions, all related to women's reproductive health. And by that time, so I was in the medical school from 2003 till 2010. Then in 2010, I moved from the medical school to the School of Public Health. So went there to head their reproductive health department, and later became the dean of that in 2018. So that was how I moved into the whole area of university administration. Then, in addition to teaching, research, and these international collaborations, was also beginning to see the administrative part of university work. It was at that time that I had a WHO connection and kind of like brought the whole School of Public Health in. And currently the School of Public Health is a major partner with the WHO. And around that time too, I began to go into the whole area of research capacity strengthening. So there were some colleagues from NYU that got to work with, and we got a Fogarty funded project, which D43, which we've actually been renewed and are running that, where we got residents, junior faculty from Ghana and from Nigeria that we trained in research methodology and writing papers. And it's really exciting to see many of them have kind of like, I mean, finished their residency training and risen in the whole academic research area. So that's essentially it. And now in this new position, I mean, I ended my deanship in 2018 at the School of Public Health, and took a 2-year sabbatical where I worked with the WHO on research capacity strengthening. Then this position of being rector at the College of Physicians and Surgeons. So this is the postgraduate medical college. We're responsible for coordinating postgraduate medical education in the whole country. So then I'm the administrative head here, coordinating different aspects of the postgraduate training. So that's what I'm doing now. So my path has been a path which essentially, I mean, if at the start of my medical school or even at the start of my residency training, somebody had told me that you're going to end up as the rector of the Ghana College of Physicians and Surgeons, I probably would have had a good laugh at that, because at that point, I mean, all I wanted to do was to practice OBGYN. I mean, at the end of medical school, what I wanted to do was to practice public health, just to be a public health physician. And then, so that's what I would have dreamt of seeing myself at. Well, that didn't work out. So I went into OBGYN. I was like, great, I'm going to do OBGYN and lecture in the medical school. Then the insight into the public health aspect of OBGYN came up. And so then I got my public health training, and it was like, great, I'll use this public health training to research in OBGYN and come out with recommendations about interventions to improve women's health, and also kind of like do a bit of practice of that. But then didn't at that point see myself kind of like going into the whole, I mean, national, international forum where we are developing interventions, developing policy, speaking to policy. But then that door also opened. And then the whole thing of like, let's say moderating published research, that came with the journal. That was also another opportunity that came out. And then the South-South collaborations with Ethiopia, Nigeria, and all that. So it's, I'm sure you've all talked with other people, but many of the times, I mean, the stories that I have heard and my own story, it's not as if you could see clearly from day one that this is the one thing I'm doing, and then kind of like constantly pursuing that. There are a few people like that, but I think essentially they're a minority. But it's more of like working hard at what one has been given to do, and then different opportunities come up. And based on the opportunities, one kind of like thinks of those opportunities, and it's like, hey, is this really what I'd like to do? Then you move into that, and other doors open, another path kind of like seems to be clearer. I mean, with the story told afterward, it's like, hey, you always knew what you wanted to do, but it's not totally like that. So I'll pause here so that there'll be room for questions. I might say some more things based on whatever questions come up. So Joe, I'm done with the main talking. Thanks.
Well, thank you, Richard. Very illuminating, and we are starting to attract questions, but I so appreciated that last point. So often people look and think that every move you've made has been calculated to your arrival at the current destination, which most of us who are getting on in our years realize that things just happen. And it's more important to get yourself in the room where doors might open for you, and then you proceed through those doors. Another thing I appreciated in your story is that sometimes what we want to do is denied of us. When you were finishing up medical school, thinking about what you wanted to go off and into, it was denied to you. And that door hadn't been opened, but you went through another one and got to the same destination. So really illuminating. What I hear from you, Richard, is you're a boundary span. You're bridging things that weren't particularly obviously bridged at the time. The first thing that comes to mind is medicine and public health. We went through such a divorce in this country, over a century ago, and it's unfortunate that public health is seen as so separate from medicine. Being in the medical school, we spend so much time and so many of our resources on the individual to the exclusion of the population. I mean, just some of your stories about as a medical student going in, doing community health, doing diagnostics on a community. We've lost that. And I know in the medical school where we would be much stronger if we had much more of an attention to population health. Could you comment on that a little bit? Here you're a physician who became the dean of the School of Public Health. How do you see that interplay between medicine and public health in Ghana or maybe other LMIC countries relative to how you see that played out here in the US?
Right. I'll pick on that, and then I'll probably touch on two questions that are also in the question box. So the whole public health versus clinical medicine thing, continues to be a big problem and a big divide, even here in Ghana and in many other low middle income countries, where you would think that shouldn't be an issue because the public health problems are all around us here. And that kind of divide, I alluded to it in the response of my attending and senior residents in OBGYN when I told them I was going to do public health. They basically were like, you're crazy. Why should you go do that? Even though in our medical school, there was, we were exposed to community health from the third year. Public health was generally looked down upon by clinicians as this is not a thing that serious doctors go and do. So it was so interesting. And then the public health physicians, most of who did not do a clinical specialty. So majority of the public health physicians are people who, after their graduating from medical school, go do an MPH and move into public health practice. At that time, not many of them even did like a whole residency in community medicine. So they also kind of like felt clinicians were narrow-minded and all that. I think on this side, I was one of the earlier people. Before me, there had been Prof. Sampov, who was also in OBGYN, who had an MPH and an OBGYN specialization. Then there's Dr. Sylvia Digan, who's also OBGYN MPH. So I think I was probably like the next generation of them. There were also two others who did that, but they didn't really practice public health. But in terms of practicing public health, probably Prof. Sampov, Sylvia, and myself. And also interesting for me to go into meetings, like public health meetings, and then when they start clinician bashing, then they kind of like pause and say, well, there are some clinicians who understand what we're doing. And I kind of like smiled. It was the same reverse amongst the clinicians when they begin the whole public health bashing. So I think there's a sense in which I would encourage more people who've specialized in clinical medicine to like look at the public health aspect of their specialization and get some training in public health and get that conversation going, because that really helps. When you understand both sides, it really helps because it's one, clinical medicine is terribly important, but then looking at the population is also important. Like I tell the public health people that something like maternal mortality, which I've worked in, is a public health problem that cannot be solved without major investment into clinical medicine. If a woman needs a C-section, she needs to have a C-section. There's no preventive health trick that you can do to prevent that C-section happening. But then also you don't want to be a doctor who just delivers baby number 6 and sends the woman home without having counsel here about family planning and that kind of thing. So that challenge is then we're still working on it. It's not as if it's solved, but definitely, more of our clinicians should be exposed to the public health side of things in all parts of the world. It's not only a problem in the US. I think it's also a problem out here. There's a question in the chat about advice for junior faculty about finding, building, optimizing global relationships. Think of it from both sides, both from the US side and from the Ghana side. I would start by saying for junior faculty, probably one thing that would help is planning to attend international conferences and looking for those opportunities. Because I've been to a number of those conferences, and for me, it was mainly the FIGO conferences that I went to. And there's some of the people that I've collaborated with that I met at these conferences, had them do a presentation and go up to them and talk, and things have come out of that. So one thing is about going to conferences. Another thing is if one gets a chance to do an attachment, like I got a chance to come over to Michigan for 3 months, there have been people from Michigan who've come down to Ghana. When one gets the chance to like move, let's say across from your continent to another, even from your country to another, for an attachment, it's important for one to have the eyes open for possible collaborations and looking for peers who will connect with you on the research or public health practice level. And at that point, I mean, it's important to be, let me say, quite discerning, because it's not everybody who really wants to go the long haul. Maybe some people you might hope to do some work with, and then it falls through. But just to keep pursuing that. Another thing which I haven't done that, although let me say I've benefited a bit from that. I mean, especially for junior faculty from low middle income countries, is to work on doing some basic research, which might not be not big, something that's big and funded, just to get your name into the space. I mean, do some audit and work on getting that audit published. And then you could get some emails. These days, there are all the spam that come through. So that's not the kind I'm talking about. But then you could get somebody from an institution, say from Michigan, from Hopkins, from Northwest. I mean, somebody who would write you from the UK and say, I've read this paper of yours. I'm interested in this subject. Can we work together? And that starts a conversation. There's another question about the role of private sector. I mean, delivering therapeutics. I mean, that's kind of like, it's a bit beyond what I'm saying, but definitely the private sector is important. I mean, like, for instance, I'll just give an example with our college here, where as we train people, one of the things that we don't see in the government sector is the whole thing about laparoscopic surgery, robotic surgery, and it's not a priority for the government. I mean, understandably, because of the other big, I mean, public health and clinical problems that we have here. But we have this kind of things in the private sector. So we are partnering with them. We are actually a government institution. We are partnering with the private sector to get residents to go in there and do that kind of training. And the private sector can also sponsor people to be trained. There are some aspects of training, so going beyond public-private partnership is sponsoring people to be trained. Like we have identified some priority areas here where we don't have many residents going into, but the private sector could go in there and sponsor the training of residents in that area. Basically, I would say that it's hard for the private sector, at least looking at it from Ghana, to just move in to begin to deliver therapeutics without working with government institutions or like quasi-government institutions. Like we have the Christian Health Association of Ghana, which is the second biggest producer of provider of health over here. And although they are like kind of like private, they partner with the government so that doctors are sent to their hospitals and they also deliver services. So that's touching on that.
Richard, I wonder if I could pick up the trail on something you've said, tie it into a few of the questions I see coming forward. You know, you've mentioned research a couple times, and you've mentioned papers. You've mentioned getting quantitative training. Not uncommonly, I'll run across students or people after they graduate where they go, I want to go do things. I don't necessarily want to go do research. You know, for clinicians, sometimes they'll say, oh, I want to go and do Doctors Without Borders. But people sometimes can see research as not being impactful. Also, there's this movement around decolonizing global health. You know, there's so many do-gooders here in the US that want to rush into settings like Ghana and say, let me help. Could you comment on that? How important is it to look at opportunities through a research or a scholarly lens? How important has that been for you? What would you recommend others?
Okay, I mean, the benefit of looking at things through the research or scholarly lens is that as one delivers service, one is asking questions. Why am I seeing this? I mean, first you're asking questions like, what patterns are emerging amongst the people that I'm seeing? Why are these patterns emerging? And what can I do to address these patterns? and improve the health of people in general. So that is where the research lens comes in. And many people who come out to say, I want to help, I want to just deliver service, I want to provide clinical care, and they go in without asking those questions. I mean, at the end, you kind of like do a lot, and you could come back some years later and see that things haven't changed at all. I mean, simply because the whole thing of asking the why is this happening? How can this be changed? What things can be done apart from just doing the quick fix? I mean, it's important to deliver service, but whilst that service is being delivered, one has to ask, how can we improve the general health of the people out there? So when service is delivered, I mean, with that kind of question being asked, it helps. The other thing that I'll say with the research lens is the whole thing of, well, you're coming from outside to deliver a service, I mean, in country. Is there a way by which, while delivering this service, you can build the capacity of people in country to also deliver that service? Because you can't, I mean, it's just not cost effective bringing people from outside all the time. I mean, they do a short thing and then they go out. So how can we improve training in the country? There are people who've come in and done a bit of that. And one of them, Joe, you know that you were together at Mayo, wasn't it? Louis Roberts and his team. They came into Ghana. I mean, they were delivering service. I mean, groups of people were coming on medical missions from Mayo. They were delivering service, but they realized that, hey, there is a gap in healthcare worker education. So they established these medical conferences, which have been going on till today, where they come in and get doctors abreast on latest developments in their field, in addition to delivering the service. Because the questions that they asked, why are these health problems there? Part of their answer was that, well, it looks like some of the practitioners don't exactly know what the current thing to do is. So then they established that. So with a research lens, one sees more and one is able to do more in delivering that. The other thing about coming in, let's say from the West, and saying, I want to come help. And there are always people who'll be telling you, let's go to hospital A, hospital B, and you can see so many patients. It's helpful when groups come in like that from the West to actually connect with the health system in country. I mean, sometimes there are some frustrations, but one needs to work through those frustrations, connect with the health system in country, so that whatever one is doing is feeding into the, let's say, the health service agenda of that country. The reason being that the health service tends to get quite a significant budget. And once you are able to convince them that what you're doing is important, there is some governmental funding or even donor support that will also go into that area. So it's important to connect with the health service, the established infrastructure to deliver things there. Now there's somebody who's put a comment here about relationship between seniors and juniors he was talking about in Ethiopia and the culture and what's the trend in Ghana. I would say that whole relationship thing where it's like extremely hierarchical amongst doctors, it's a thing that is changing. Let's say it's changing in Ghana. I mean, when I talk with my seniors, it was very bad in their time. I mean, it existed a bit during my training time, and it's changing. But there'll always be some people who kind of like feel it's a seniority thing, looking down on who's down there. I was surprised when I discovered that training from England, this was somebody who trained in England, who said, I was surprised that there was actually a term to it, which they called learning by humiliation. And I remember when this older professor said, I said, you mean that was coined when you were training? I said, yes, it's a kind of tradition, but it is changing, and where there's more dialogue, I mean, between seniors and juniors, between medical students and their teachers, residents, and their attendings. But it's not exactly where we would like it to be. And somebody was asking something about partnering with public health entities to implement their program. And I think what I said a bit about connecting with the established infrastructure is the same advice I would give there. Working in gender-based violence and then developing some interventions for reducing that. It would be good to go in Kenya and at least talk with the Kenyan Health Service. Get to talk with some of those administrators, meet with them, and you'll be surprised at how relatively easy it is to walk into an office and say, I want to talk to the director to say what I'm doing. Better still if you get some Kenyan partners who are then connected with the health service administrators and can take things over there. Yeah,
Richard, I'm impressed with the number of questions you're getting, as well as well-wishers who have been influenced by you over the years. I'm going to do a little bit of merging with some of these. So often those of us in privileged countries come in with a big brother type of attitude that what we have to do here is unidirectional. We can help you. We don't go in so often with a viewpoint around appreciative learning. Are there things that you see in Ghana, in your system, or in your journey to date? Do you think that you wish we would learn from you on, or that we would learn from Ghana on how we're navigating better health?
What you learn from Ghana? Well, let me say the first thing to learn when people are coming in from a high-income country is that however much you try, however much you talk, there is a power gradient. There is a power gradient. Even the medical student who comes in, who's a medical student from, say, University of Michigan coming to Ghana, there is some kind of power gradient. And that's a thing that you've got to learn to live with, because it's not going to go away just based on how the countries are. And because of that power gradient, one of the things to be, learn to be as quiet as the people that you're around are when you start. You're talking and the people are not talking. Well, you've also got to stop talking at some point and basically ask them, so what do you think? Because generally speaking, most people are not going to talk. They're going to listen and they're going to say, everything you're saying is a great idea. And when you go, then they'll kind of like laugh about how you really don't understand what's going on. So it's helpful to kind of learn to be a bit quiet and hear people. And when you begin to tell people that they should talk, many people would begin to talk. Another thing to learn is the fact that in this part of the world, we are more community-based. It's more of like communal behavior type of thing. Many times people from the West come in and it's like, let's pick one or two champions and let's invest everything in them and they are going to be able to change things. It's good to do that, but at the same time, it's also good to get the community behind them. And by the community, like if you want to focus on training doctors, think about the nurses, the physiotherapists, the other people who are there. Is there a team type of thing that can be done? Learn to listen to the community and do some of the things that they say are important to them, even if you don't think that's that important. Just doing that one thing will be able to open the doors for many, many other things. So those are some of the things that I would say. And there's also kind of like, how do I put it? There's a lot of historical wisdom. I'll give an example. Something that kind of like shows that historically Africans have always known that maternal mortality was a big problem. The Yoruba tribe of Nigeria are people who have a greeting for almost everything. And I was surprised to discover that the greeting that they give to women who've delivered is the same greeting that they give to people who've come back from war. So that shows that ethnographically, the whole challenge of maternal mortality is known by the people. So listening to some of the local stories that exist would help a person know what the people consider important. And that's what, if you address, you'll get the support of the people, right? So there's somebody asking about how to stay in contact. I'm sure once you get in touch with the center, I'm happy for my email to be shared. Alana could share it and you could send emails. I might not answer the first one, but by the third one, I'll definitely realize that you're dead serious. So I've got to
picking up on that last point, Richard.
Yeah.
we have a very vibrant arts community here that engages with the community. Could you comment? I also see much more powerful community engagement when I'm in Ghana. Is there the role of the arts in advancing health in Ghana? We're going to maybe get into a few questions that have specific health issues, but this question was referring specifically to gender-based violencing. I'm wondering, is there the role of the arts that you see in advancing health in Ghana?
No, there is definitely a big role for the arts. I would say traditionally, we probably haven't made much use of the arts in improving health out here. But then there's a big role. There are things like there's some great adverts on TV that are health promoting adverts. There's some great plays that people have put out that have probably delivered a health message better than the so-called educational talks that health workers give. So there is greater collaboration growing now where we, the physicians, are working with social scientists, working with communicators to kind of like develop our messages. But there is a major role for the arts in improving health. And it's not been, let me say, it's not been tapped as much as it should be. And that kind of, let me say, collaboration and support is definitely very welcome out here.
Good. We have another one kind of wondering about inclusivity, big issue for our university, for our times here in the United States. What types of changes are afoot with regards to things like transgender, intersex, non-binary people, particularly around reproductive health in Ghana? Do you see things evolving?
So let me say that generally speaking, that is an evolving area. It's an evolving area out here. I mean, in recent times, there is more talk about transgender, intersex, and all that in the area of reproductive health. There are advocacy groups that exist in the country that talk against discrimination and all that. And generally speaking, in our training, I mean, the training is that the whole aspect that people have a right to healthcare. I mean, regardless of their religion, I mean, tribe, background, I mean, gender, sexuality, or whatever. It's what we tend to teach. And then the whole thing of like, if a person, for some reason of conscience, says that I'm not willing to or able to provide this service, people are required to refer the people to another place where they can get the service. All this is written into our policy. But it's easier writing it into policy than it coming out into practice. There are some challenges, but then the whole aspect of let's say violence against people who are transgender or who are LGBT, it's not a big thing out here in Ghana. And at the same time, what I would say is that where we are now is that generally speaking, traditionally, most people would not want to be seen to be coming out kind of like appearing to be supporting these like transgender LGBT kind of thing, just because of the cultural situation. So, but there are many people who would not discriminate against them and would provide the appropriate care and service. So I think sometimes in kind of like addressing these things, it probably helps not to come out like waving a banner and saying we are standing for this. Then people generally tend to like resist because of the whole tradition and culture thing. And I'll give you a story to do with Ghana's abortion law. When you read Ghana's abortion law, the abortion law could look like the most liberal abortion law, because it's like, I mean, women can have an abortion and under the following circumstances. And then it's listed. I mean, everything kind of like comes there. Health, social problems, mental problems, it's all listed there. However, the law starts with a statement that any woman who terminates a pregnancy or is helped to terminate a pregnancy has committed, or anybody who helps a woman terminate a pregnancy has committed a crime. Then all these provisos are there. So there have been many people who've come in terms of the whole women's rights thing and said, let's take this thing into parliament and let's have that first line expunged. And many of us have said, please be careful about that. This law was put down when it wasn't kind of like a parliamentary government kind of thing. If you take this into parliament and I want to have that first line expunged, you might end up getting people standing up and coming up with a more rigid law than what exists. But the current law allows this service to be provided. So why don't we just kind of like let sleeping dogs lie, rather than wanting to push to have a law saying a woman can have a termination for whatever reason and it is not a crime. That's where one kind of like needs to engage with the culture and try to not be too confrontational. Sometimes the problems have come because people want things written out straight. So this is kind of like a middle road. But where the culture is now, I think if people come out being confrontational, it's going to end up probably hurting these groups more than helping them. But the system now actually has a number of people who would provide the care, provide the support, and not discriminate, against them. And that's what we tend to teach. Yeah.
Well, very good. We're definitely wrestling with that in our communities. How do you try and advance and enlighten, but how do you bring people along? How do you create allyship rather than the polarization that we see so present in today's society? Richard, I'm just surprised at how quickly this time went and how we have to wrap up here, but we're so thankful for the hour you've spent with us, for your partnership and collaboration over the last 25 years. And I know we're working on more and deeper plans for collaborating in Ghana, thanks to your leadership. So we're very grateful for this opportunity. Thank you for spending this time.
Thank you so much, and bye-bye.